Pyrexia, which is commonly known as fever, is the elevation of an individual core body temperature above a set point. Set point is regulated by the body's thermoregulatory center in the hypothalamus. This increase in the body's set point temperature is often due to a physiological process brought about by infectious cause or non-infectious cause. Infectious cause such as inflammation, malignancy or autoimmune processes. These processes involve the release of immunological mediator which trigger the thermoregulatory center of the hypothalamus, leading to an increase in the body's core temperature. The normal temperature of a human body is approximately 37 degrees Celsius or 98.6 degrees Fahrenheit and varies about 0.5 degrees Celsius throughout a day. This variation in core body temperature results from normal physiological process throughout the human body, including metabolic changes, sleep-wake cycle, hormones variability, and changing activity level. However, in case of a fever, the increase in the core body temperature is often greater than 0.5 degrees Celsius. And is attributed to a fever-inducing substance pyrogen. In adult human, fever is defined as an oral temperature above 37 degrees Celsius or 98.6 degrees Fahrenheit, or a rectal temperature above 37.5 degrees Celsius or 99.5 degrees Fahrenheit. The most common cause of a fever is a viral or bacterial infection or bacterial toxins. In almost every instance, there is a specific constituent, the endogenous pyrogen, that directly trigger fever production. While this number may vary slightly based on the source, let's categorize fever. Low grade, moderate grade, high grade, and hyperthermia or hyperpyrexia. Low grade fever range from 37.5 degrees Celsius to 38 degrees Celsius or 99.1 degree Fahrenheit to 100.4 degree Fahrenheit. Moderate grade range from 38.1 degree Celsius to 39 degree Celsius or 100.6 degree Fahrenheit to 102.2 degree Fahrenheit. High grade fever range from 39.1 degree Celsius to 41 degree Celsius or 102.4 degrees Fahrenheit to 105.8 degree Fahrenheit. Hyperthermia is greater than 41 degree Celsius or greater than 105.8 degree Fahrenheit. It is essential to understand that the definition of fever is not the same as the hyperthermia or hyperpyrexia. In fever, there is increase in set point temperature brought about by hypothalamus and general functionality of all organ system. In hyperthermia, however, the rise in the body core temperature is beyond the confined set point. Let's assume the set point controlled by hypothalamus is 8 degree Celsius. If hypothalamus increase the core body temperature and is controlled, but hyperthermia is beyond the set point temperature. And hyperthermia is not regulated by hypothalamus. An issue of concern that should be addressed when discussing the concept of fever is understanding that the site of measurement influences body temperature reading. The above axillary temperature reading is 35.97 degree Celsius or 96.75 degree Fahrenheit. The urine temperature is 36.61 degree Celsius or 97.90 Fahrenheit. Tympanic temperature is 36.64 degree Celsius or 97.95 degree Fahrenheit, and rectal temperature is 37.04 degree Celsius or 98.67 degree Fahrenheit. It is also important to consider the patient's normal baseline body temperature. If patient typically runs cold or hot, then their baseline body temperature may be decreased or elevated above what is considered normal and does not necessarily indicate a fever or febrile illness. A final issue of concern is that while patient can state they have a fever because they feel warm, it is noted that the diagnosis of fever based on palpation is unreliable and inaccurate. If a fever is suspected, an official reading should be obtained. Let's study cellular mechanism of fever. Milton and Wendell demonstrated that fever is mediated by pyrogenic activity of prostaglandin, specifically PGE2. The synthesis of PGE2 begins with the membrane phospholipid being converted to arachidonic acid by phospholipase A2. Arachidonic acid is then converted to PGS2 via cyclooxygenase or COX pathway, after which PGS2 undergoes isomerization to PGE2 by PGE synthase. PGE2 acts via the EP3 receptor to affect a specific neuron within the hypothalamus that aid in thermoregulation. Medication inhibit the COX pathway are mainstay of treatment for fever. The action of PGE2 begin when the exogenous pyrogen stimulate endogenous pyrogen such as interleukin 1, interleukin 6 and tissue necrotic factor. These factor and interleukins augment T and B cell response to interleukin 1 and interleukin 1, interleukin 6 and interferons to alter the hypothalamic set point via the organum vasculosum of lamina terminalis and raise the body core temperature. Above a set point. Endogenous pyrogen also act to trigger an immune and inflammatory response, include leukocytosis, T cell activation, B cell proliferation, natural killer cell killing response, and increase WBC adhesion. The inflammatory response include increased acute phase reactants, increased muscle protein breakdown and increased synthesis of collagen. Hypothalamus increase body core temperature by the set point and its augment mobilization and deployment of host leukocyte, especially neutrophil. And neutrophil that increase immunological response to pathogen also increase host defense. Endogenous pyrogen, interleukin 1, interleukin 6 and tissue necrotic factor, that is endogenous pyrogen disrupt segmented neutrophil granules to release lactoferrin. Lactoferrin is much better chelating agent for iron than normal plasma transferrin. that stimulate uptake of iron by liver. Intestinal absorption of iron is decreased and decreased free iron in plasma and extravascular tissue. That also increase host defense. Let's go with organ system involved. Fever induction in human occur at a high metabolic cost, such that only 1% rise in the body temperature require 10 to 12.5% increase in metabolic rate. Metabolic effect associated with a febrile state. Metabolic effect increase oxygen demand, which increase heart rate and respiratory rate. Metabolic effect increase use of body protein as an energy source. Metabolism switches from utilizing glucose, which is an excellent medium for the bacterial growth, to utilizing the breakdown product of protein and fat. Metabolic effect enhance immune function, which increase in the motility and activity of white blood cell and stimulate interferon production and activation of T cell. Growth inhibition of a specific microbial agent. Many microbial agents that cause infection tend to grow at normal body temperature. A sustained severely elevated fever can lead to lethal effect with multiple organ system, brain, cardiovascular system, GIT, liver, kidney and hemostasis. Let's talk one by one. Brain. Acute neurologic and cognitive function may occur after an episode of hyperthermia, with approximately 50% of heat stroke survivor experiencing chronic neurologic damage. Specifically, the Purkinje cells in the cerebellar cortex are sensitive to heat damage, which can lead to long-lasting cerebellar dysfunction. In CVS, acutely hyperthermic patient will tend to be hypotensive with a high cardiac output due to blood redistribution and nitric oxide induced vasoconstriction. In severe fever, such as heat stroke, an ECG may show T-wave abnormality, QT and ST changes, and conduction defects. In addition, serum troponin I level may be significantly raised. In GIT, above 40 degrees Celsius or 104 degrees Fahrenheit, there is a reduction in blood flow to the GI tract. In addition, oxidative stress, denatured protein, and damaged cell membranes are evident, increasing the potential for releasing pro-inflammatory cytokines, GI inflammation, and edema. In liver, elevated liver enzymes are observed in individuals with body temperatures above 40 degrees Celsius, with severe cases leading to permanent hepatocellular damage requiring a liver transplant. It is important to note that liver function may continue to decline even after correcting hyperthermia. For this reason, a clinician should train the patient's liver enzymes to ensure no ongoing liver damage exists. In kidney, patients with an increased body temperature are at a significantly greater risk for acute kidney injury. An increase in body temperature by only 2 degrees Celsius leads to a decrease in the glomerular filtration rate, which continue to fall with a further rise in temperature. Lab study will show an increase in plasma creatinine and urea. Additionally, a hyperthermic state stimulates the renin-angiotensin-aldosterone system, leading to subsequent reduction in blood flow to the kidney. In hemostasis, inhibition of platelet aggregation, spontaneous bleeding, increased clotting time, thrombocytopenia, increased plasma fibrin degradation productions are classically seen in the hyperthermic patient. Now go with the functions. The fever responds a systemic reaction to an infection that has evolved in warm-blooded animals for over 600 million years. An increase in core body temperature is known to improve survival and resolve infections, while an increased body temperature subsequently lead to an increased metabolic cost. It is known that the survival benefit outweigh the metabolic cost associated with a fever. An increase in core body temperature acts as an alert system to activate immune surveillance via different cell type including natural killer cell, dendritic cell, macrophages, T and B lymphocytes, neutrophils and vascular endothelial cell. Now go with the diagnosis. A diagnostic approach to fever or hyperthermia include the following. Vidal test, which is going for the typhoid fever. Dengue IgG IgM test for the dengue fever. TSR increase in the fever. Let's go above 70 mmHg. C-reactive protein is also increased in fever. Procalcitonin elevated in certain bacterial infections. Then tuberculin skin test. If doctors suspect TB, recommend Montauk's test with following sign and symptom. That is night sweating with fever, unexplained weight loss, tiredness, fever, which is main symptom, loss of appetite, and cough that lasts for a long time. Fever also induced in HIV. Serum LDH level is a predictor of ARDS in SARS-CoV-2 infected patient with fever. Routine blood culture is also going for the differentiation in bacterial or viral infection, and other measure is also taken in the blood culture. Rheumatic fever is a common cause of acquired heart disease in children. ANA test is used as an initial screen in patients with non-specific clinical symptoms such as fever, joint pain, myalgia, fatigue, rash or anemia. The likelihood of a positive result due to infection will increase, especially in children. Heterophile antibody are antibody induced by external antigen. Some cross-react with self-antigen. For example, in rheumatic fever, antibody against group A streptococcal cell wall can also react with the human heart tissue and thus damage. Elevated level of CPK associated with fever. The other feature for that confirmation is low level of consciousness, dehydration, muscle tenderness and tremors. Serum protein electrophoresis for myeloma, severe anemia and plasma cell level detection. Imaging studies is also taken on the basis of history. CNS signs should prompt, then lumbar puncture should be done. Patient with a travel history of malaria endemic region should be tested with thick and thin peripheral smear. Rule out of thrombophlebitis and infective endocarditis in IV drug abuse. Thrombophlebitis, which is deep venous thrombosis, sometimes resulting in thrombophlebitis, lead to systemic inflammatory reaction of the body including fever. Several other specific tests can be performed based on the history and physical examination finding in patient of varying age group. A detailed history and thorough physical examination of all body system can help narrow the list of differential diagnosis. Now go with the pathophysiology. Patient with fever usually exhibit warm, flushed skin, tachycardia, involuntary muscular contraction or rigors, and sweating or night sweat. Piloerection and positioning of the body to minimize exposed surface area are also seen. Occasionally, these signs are absent or minimal, and dry, cold skin or extremities are detected despite a significant rise in core temperature. Fever occurs when either endogenous or exogenous pyrogen cause an elevation in the body thermoregulatory set point. In hyperthermia, the set point is unaltered and the body temperature becomes elevated in an uncontrolled fashion due to exogenous heat exposure or endogenous heat production. Hyperpyrexia is the term for exceptionally high fever greater than 41 degrees Celsius, which can occur in patients with severe infections. Hyperpyrexia may also be seen in the patient with CNS hemorrhages and is associated with a poor outcome. Elevated brain temperature may lead to increased intracranial pressure, ischemic brain injury, exacerbation of cerebral edema and death. Inhibitors of cyclooxygenase, for example, aspirin and acetaminophen, which is commonly known as paracetamol, can help reduce fever. Observation of a pattern of fever can be helpful in certain conditions. For example, a fever that occurs every 48 to 72 hours occur in certain type of malaria and a fever that occurs predominantly in the evening is a typical of tuberculosis. The everyday highs and low of typical temperature are emphasized in many fevers. However, this variation might be turned around in typical fever and disseminated tuberculosis. Temperature pulse dissociation curve in typhoid fever, brucellosis, leptospirosis, some medication prompted fever, and factitious fever. In healthy, expansion of the pulse of 4.4 beats per minute for each 1 degree Celsius or 2.44 beats per minute for each 1 degree Fahrenheit. Increase in core temperature. During infection, fever may not be observed in babies, older adult, patient with chronic kidney disease or patient taking corticosteroids. Instead, hypothermia may be present. The most common cause of fever in clinical setting is sepsis account for most of fever in hospitalized patients. Malignancy, tissue ischemia, and drug reactions account for most of the remainder of the fever seen in the hospitalized setting. Rare cause of fever include neurogenic fever and fevers associated with endocrinopathy. Now go ahead with the clinical significance. While we have talked in detail about what constitute a normal and abnormal temperature, given the many factors influencing the result of temperature measurement in humans, there can never be a single universally accepted temperature cutoff defining a fever. This clinical reality, however, does not remove the need for precision in measuring and reporting fever. While most patients with an elevated body temperature have a typical fever, there are some instances in which the body temperature increase above the fever threshold, termed hyperthermia or hyperpyrexia. Hyperpyrexia may typically be seen in heat-related illness such as heat exhaustion and heat stroke, which are usually caused by overexertion and dehydration in a hot environment. Other causes include obesity, metabolic conditions, adverse drug reactions, and age, with individuals under 4 and greater than 65 years old at an increased risk for a heart-related illness. In contradiction to fever, in hyperpyrexia, the thermoregulatory set point remain unaltered at normothermic level, while body temperature elevates in an uncontrolled manner and beyond the capacity to lose heat. Heat exhaustion, temperature above 38 degrees Celsius or 100 degrees Fahrenheit in the presence of any of the following symptoms: increased sweating, pale, clammy, cold skin, generalized weakness, tachycardia with weak pulse, nausea or vomiting, dizziness, lightheadedness or fainting. Then heat stroke, temperature above 40 degrees Celsius or 104 degrees Fahrenheit in the presence of any one of the following symptoms: hot, red or dry skin, tachycardia with a strong pulse, delirium, convulsion or coma is present. Fever suppression. Fever are typically managed with antipyretics, which work by inhibiting the enzyme cyclooxygenase COX pathway, thereby reducing the level of prostaglandin E2 within the hypothalamus. Other mechanisms of antipyretic have been suggested, which include reduction in pro-inflammatory mediator and enhancement of anti-inflammatory signals at the site of injury. While one may feel inclined to give an antipyretic to all febrile patients, this is not recommended. Some antipyretics may cause patient discomfort, predispose patient to adverse effect from other medication ingested, or interfere with the accurate assessment of patient receiving antibiotics. Over-the-counter antipyretics include acetaminophen and NSAID such as aspirin, naproxen, ibuprofen. Instrument used in diagnosing fever. Digital sublingual thermometer. A temperature probe is placed under the patient's tongue with the lips closed around the instrument. The patient should not have recently smoked or consumed hot or cold substances. Digital thermometer are recommended over glass thermometer as they have a disposable probe cover and give result in approximately 10 to 20 seconds as opposed to 3 to 5 minutes for a glass probe. digital rectal thermometer. They are indicated in children and patients who cannot fully corporate. A lubricated blunt tip thermometer should be inserted approximately 4 to 5 cm into the anal canal at a 20-degree angle from the horizontal with a patient in a prone position. A rectal temperature reading is the preferred method in patients suspected of hypothermia. A rectal probe and a thermocouple are essential for measuring temperature as low as 25 degrees Celsius or 77 degrees Fahrenheit. Infrared forehead thermometer. This method involves taking a temperature measurement a short distance from the frontal bone without contacting the skin. Devices such as this function by converting infrared radiation from the forehead into an electrical signal, which is then used to determine a temperature reading. This is the preferred method for non-contact temperature reading as it requires no cleaning between individual readings. Infrared tympanic thermometer. This method detects infrared radiation from the tympanic membrane and convert it into an electrical signal, which is then interpreted as a temperature reading. This method involves patient contact and requires cleaning after each patient. Infrared temporal artery thermometer. This method utilizes a thermometer that records temperature by slowly moving the device from the center of the forehead over the lateral hairline. This detects infrared radiation emitted from the skin over the superficial temporal artery. This thermometer takes up 1000 readings per second and report a highest temperature. An algorithm is used to adjust for ambient temperature and calculate the core temperature. Thank you. Don't forget to like, share and subscribe my channel.